possibly that's been done at an NZAP conference. We have 3 TED Talks. And the TED Talks, the TED stands for Technology, Entertainment and Design. And it's based on the educational theory that we have an attention span of about 18 minutes. Or at least that there is some benefit and some rationale to having shorter presentations. So whilst we tend to be expansive, and perhaps particularly in the field of psychotherapy more so, this is an opportunity to be a little bit short and sweet. So we have 3 presenters, and the reason I got the hosting gig is that I have some association with each of them. Josie was kind enough to appoint me, so if you have any problems with me, it's her fault. And has been a very considerate and kind manager until this year, where we reversed roles and I'm now her manager, which is also a delight. Mark also works at AUT and is the head of psychology. And Rod Sandle, I got to know a little bit in Wellington, been around for many years. And I have some good friends by the name of Evan and Isabel Sharard. And Isabel said to me the other day, I'm Rod Sandle's sister-in-law, so I'm going to introduce Rod as Isabel's brother-in-law. So I'm delighted to have all 3. It's going to be a challenge keeping time. Somebody said that we would give a chocolate fish to the person who came in on time, so maybe we'll be giving 3 chocolate fish away. So without further ado, I'm going to invite Josie Goulding to speak on the topics of bumps or battles, and for 18 minutes. And there will be an opportunity within the whole time frame to have a few questions and answers as well. So, kia ora, Josie.
Thanks, Keith, for that lovely introduction. I've had a slightly bad day, which will come to light as we go through the presentation. But the first thing is that the technology part of the TED Talk isn't working, so I'm afraid you're just going to have to listen to me without the slides. So this is a presentation about a pilot study, which was an interpretive phenomenological exploration of mind-body therapy with patients with chronic urticaria. In presenting this paper, I first want to thank the people that contributed to making this possible. First, the patients who agreed to participate in the study, and there were 4 of them. Secondly, Brian Broom, who agreed to both be the clinician and also participate as a subject of the study by providing his reflections on the therapy experience. And Brian was intending to be here this afternoon for the presentation, but and I can feel myself be quite emotional here. Sadly, his daughter, who has a long-term illness, died yesterday, and he isn't able to be here. So I really want to honour him in this presentation. And thirdly, I want to thank both the Auckland Immunology Department and AUT University for providing the funding to make this possible. And lastly, I want to thank and acknowledge my fellow researchers, Margot Solomon and Dr. Karen Lindsay. This paper discusses a pilot study that explored the phenomenological experience of patients suffering from chronic spontaneous urticaria and the treating clinician in order to develop a deeper understanding of the healing process. A further aim was to investigate the effectiveness of a mind-body approach for treating health issues. There has commonly been a split between a medical and psychological understanding of illness. Most people who have a physical illness will initially present to a medical service believing that they have a purely physical condition. Most medical services respond to patients from the same belief system. Often a physical intervention is sufficient to resolve their condition, but in many instances it is not, nor is it the optimal response for the health of the individual. The mind-body therapy approach educates practitioners to challenge this split and to see the patient and their presenting condition as a complex whole that is best served by engaging with them from this perspective. MTA is taught as a specialist area of practice at AUT, and there is a need for research to explore the efficacy of this approach. MTE is of particular interest to the healthcare system in chronic conditions that do not respond well to traditional medical intervention. Chronic spontaneous urticaria, which is an itchy rash which looks like an allergic reaction and is commonly known as hives, is one of these conditions. It is a common condition presenting for treatment in the immunology department at Auckland Hospital. The immunology department was already using a mind-body approach with some of their patients, and they were keen to audit this choice of treatment. This meant it was an easy and accessible choice for the study. The clinical team was interested in the outcome as it could directly contribute to their understanding of their work. The MTA approach requires the clinician to have the skill to be with and to educate patients to a more whole-person view of their condition, which honours the obvious physical reality of it, but also allows the psychosocial factors to be rendered visible and resolved. This means the clinician needs to have a non-dualistic model themselves. The clinician works with the patient to facilitate the expression of their whole experience, including the affective component. As well as the skills of listening and reflecting, it includes the more specific psychotherapy skills of identifying psychodynamic and relational themes and empathically responding. The study as a whole had several components to it. The interpretive phenomenological analysis was primarily carried out by Margot Solomon and myself. We wanted to investigate the experience of patients and the clinician during the therapy process for this specific chronic condition, and we were looking for themes that reflected or spoke to the essence of their experience, of their presenting issues and their therapeutic journey. In doing this, we also looked at the therapist's experience of the patient and the therapy. Dr. Karen Lindsay undertook a grounded theory study alongside, looking at the patient's transition from a traditional medical model to a mind-body therapy approach. And Karen also gathered quantitative data looking at disease measures, quality of life measures, and medication usage. Interpretive phenomenological analysis is a methodology that has emerged in the health professions over the last 15 years, primarily through the work of Jonathan Smith. IPA aims to explore in detail the participants' view of the topic under investigation, and for this study, this was to look at the patient and the clinician's experience of what was significant in the therapy. We used their written record, sent via email to us, of their experience of the therapy, including what had stood out for them and in the sessions and following the sessions. The phenomenological aspect of this is the participant's personal perception of the event. The event can be thought of as the therapy session. The interpretive aspect of the methodology is derived from a symbolic interactionism, which argues that the meanings individuals ascribe to events should be of central concern to the social scientist, but also that those meanings are only obtained through a process of interpretation. It is interpretive because the process is dynamic. As the researcher attempts to understand the patient's and clinician's perspective, they use their own perception to make sense of what they are taking from the words of the patient and the clinician. This aspect of the methodology is also hermeneutic, and following Heidegger, IPA is concerned with examining how phenomena appear, and the analyst is implicated in facilitating and making sense of this appearance. Patients were recruited through the immunology department. They were diagnosed with chronic spontaneous urticaria and had already been treated biomedically without success. They were selected as suitable for the study by the medical member of the team, and once they had been introduced to the study and had given their consent to be participants, they began a series of 10 psychotherapy sessions with a senior immunologist who practices the mind-body approach. Both patient and therapist undertook to send an email to the researchers following each session, and the researchers had a set of questions that were used as cues for the patient particularly. For example, describe the most memorable experiences you've had in your session this week. What sort of feelings, sensations or thoughts did you notice during or after the sessions? The researchers responded briefly and from time to time to ask additional questions, and the transcripts were analysed and coded, looking for themes and factors that stood out. This was done for each patient and therapist treatment, and then these themes were gathered across patient and therapist interactions. The data was analysed email by email using the computer program in vivo. I will mention here our review and critique of the method. We did not find the email responses of the patients as rich in data as we would have liked. In fact, it's why we stopped the study at only 4 patients. In retrospect, this could perhaps have been predicted given the patients presenting issues. The level of reflection and anecdotal material was very limited for the most, but not all of the participants. I have ended up including some of the exit interview material in the analysis. Both Margot and I were involved in some of the exit interviews, and Karen Lindsay completed the rest. These interviews proved much richer in material as the patients could be actively encouraged to be reflective. In retrospect, Margot and I felt that we were too restrained in asking questions during the therapy phase because of our worry of interfering with the therapy. For any future study, we would like to analyse the actual therapy sessions, post-therapy interviews for richness of analysis. So what's an overview of what emerged? I have divided the themes into those themes that the patients presented with in starting the therapy. They are represented under what we coded more generally as a way of being, which included the urticaria. The second general theme is to do with the therapy process. So, a way of being. I've clustered a number of separate but interlinking themes under this heading. Relationships, emotional expression and action, reflection and making meaning. The patient's relationships were characterised by conflicted connection with themselves and close others. In every case, the patients presented with internal conflict between competing values, and this was enacted in their relationships. Examples of how these conflicts were expressed were, in these quotes, "Don't cause a problem, don't make a fuss, hide feelings, I should have done more, I have to manage, the responsible one, others are more important," versus feeling burdened, feeling oppressed, feeling taken advantage of, undervalued, overworked, alone. These patients recognised that there was personal and relational stress. The link between this and their internal conflicts varied but are tentative. They did not, however, initially link this to the urticaria, which is primarily seen as linked to food allergies. This, for the most part, has often been reinforced by their previous medical treatment, even if the food allergy was not conclusive. Often in retrospect, they will say they suspected a link to stress. These conflictual aspects of their experience are generally unprocessed with little reflection, linking or meaning-making of thoughts and feelings or actions and events, and the conflicts are often expressed as felt guilt. Starting to express themselves in the therapy was often the first time these feelings had been expressed explicitly, or certainly to another person who listened and responded empathically. Patient C said, "I have never felt comfortable in my life. I have always felt a lot more guilt than saying, well, that's looking after my own feelings. And even expressing my own feelings to people close to me, I've never felt that was kind of, it's not my right. It was something I didn't do, expressing my feelings. Saying, I am finding this difficult, I would like, can you help me or can you come with me? I took that away, that it was probably the biggest thing I took away." Patient B said, or at least with patient B, the therapist said, "Pent-up feelings of anger were evident from the first minute or so," and the patient said, "It opened a floodgate about feelings I have held back from my family, partner and friends, guilt about being a burden." With patient A, the therapist said, "There is a pervading sad anger," and the patient said, "I had no real emotions until the therapist suggested my wife and son attend the next meeting, when I had a strong feeling of apprehension, embarrassment." Our observation is that while clients may not personally be aware of it, initially anyway, there was a short-circuiting of emotional expression, both as a clear signal to themselves and or to others. The problem or fear of emotion, in particular fully feeling and expressing their anger, frustration and resentment and aloneness, was a clear theme that held sub-themes of how they managed this. For example, separating thinking and feeling, keeping busy, physical manifestations of emotional pain, and that was not just the urticaria, but for example, diarrhea, losing their voice, and angioedema, which was a related condition. There was generally a difficulty in close relationships, particularly with the expression of difficult emotions, and this way of being was also present in the therapy space and is expressed in the second group of themes. The second set of themes related to the therapeutic relationship and process. Overall, we coded it as unsettled state of being. This included questioning and reviewing their relationship with themselves, attributing meaning to their urticaria by linking it to their own story rather than a food allergy, and addressing relational difficulties. The therapist was able to build trust quickly by being alongside rather than taking the expert role, and the themes of active listening, empathic engagement, and linking through psychoeducation were clearly present in the emails and transcripts. By the third session, all patients had had an outbreak of urticaria or other physical manifestations of distress due to the emotionally challenging nature of the different expectations in the therapeutic relationship. And these were expressed in the emails and interviews transcripts. This flare-up highlights the client's difficulties and unsettles their way of being. The therapist at this time is consistent in staying clear about the cause of their illness being in their own story rather than having a solely organic cause. While all the patients experienced the therapeutic relationship as warm and empathic and valued this, 3 of the 4 actively expressed how difficult it was to do things differently. For example, talk about their feelings and accept the link between their experiences or story and the urticaria. The combination of the unsettled state of being and the therapeutic interventions stimulate the client to explore new actions in their life. These are thematically represented in 2 forms. One was to confront or address the relational difficulties they were involved in other words, the battles. The other is to begin to question and review their relationship with themselves. In this way, it seemed to us their patients made a choice to continue with the bumps or engage in the discomfort or battle of confronting and expressing their anger. Both of these actions are resonant in the therapeutic setting. The therapist interventions at this time include the themes of active listening, deep empathic connection, making links, directly addressing the relationship between the therapist and client, holding, helping find words for what's happening inside and outside of the therapy room. The use of metaphor was an aspect of this, and psychoeducation, which facilitated emotional expression in the therapy. The therapist said, "I felt like a coach driver, pulling on the horse's reins constantly to get the nice horse to point in another direction. Once that was achieved, it would go all right for a little, and then I would have to do it again." Key in this was the capacity of the therapist to engage in the present with what was happening between the therapist and client. This seems to have given the clients a new baseline for what could happen between people. The therapist said, "She has a yearning to be accompanied, nurtured, understood, accepted in her vulnerability. But in the process today, as I directed my attention to her feelings, her vulnerability, so she skidded off into another cognitive circuit of problem solving to sustain coping. But gradually she started talking more softly and gently, owning her need to be seen and understood." A patient said, "I've had a significant change in my expectations of when the outbreaks will happen. I'm not anticipating reactions and taking very little medication. More aware of how I'm feeling, trying not to suppress feelings. This seems to be successful. I'm learning to stand back and cope better if things are not, as I see it, in control." At the conclusion of the 10 sessions, all 4 clients were off their medication and had significantly reduced symptoms. While this was a pilot study and had a very small number of participants, it allowed insight into the patient's presenting themes and the processes that were mentioned as significant in the therapy. It also showed the patient's improvement through quantitative as well as qualitative measures. To further understand what is helpful and to develop a more significant study looking at the effectiveness of MTA as an intervention for chronic spontaneous urticaria or other chronic conditions, a larger study would be indicated. Thank you. And
Do you want to take a couple of questions?
I don't mind. Yeah, it's fine. Yeah, it's fine. Yeah.
We have time for just a couple of questions for Josie.
Thank you very much for a very interesting report, I suppose, on your research. I'm very interested in phenomenological research, and so I found myself listening in all sorts of ways, listening to where one pitches their research, what you examine, how you choose your method, and so on. And a couple of things struck me. I mean, I think a study of 4 people, a phenomenological study of 4 people is absolutely fine, because the phenomenon needs to come through in the best possible way. And if it takes, and 4 people do it well, it's a huge much better than 20 people doing it badly. So I didn't see that as a kind of limitation. I was really struck that I wasn't sure what you were investigating, though, because it seems that some of it is about the lived experience of having the urticaria, and then some of it was about the lived experience of undertaking psychotherapy for the urticaria, and some of it was the psychotherapist's experience of delivering psychotherapy for urticaria. And so I thought there were a number of foci there, which I think is wonderful, because I think that's something that if you had a lot of students who want to do some research, there's a lot of unpacking that can be done. So I found it really stimulating, but I found it increasingly stimulating to think about how much more you could do with it. And you may want to respond to that, but it's just really a comment, I suppose.
It was very interesting, because we, in a sense, what came out was to some degree stimulated by the data we actually ended up gathering. So we started up with just wanting to look more broadly at the experience of the therapy, but what clearly came out was these themes. So that's how we ended up breaking it down. Yes, lots more that could be done with it. Yes, thank you. IPA, interpretive phenomenological. Interpretive phenomenological analysis.
Thank you. I'm sorry. In terms of having 3 presenters, so we're going to thank all the presenters at the end. So, but thank you, Josie.
Ti he Māori ora, e tama, e papatuanuku, tēnā koe, e tūnga mō ngā uri whakatipu. E te whare, tumutumu whenua, tēnā koe, he wai puna I te whenua. Nō reira, rangatira mā, tēnā koutou, tēnā koutou, tēnā koutou, katoa. In 1968, when I was in my first year of psychology at Canterbury University, I remember being shocked when our professor told us that Freud believed that children were sexual beings who could be sexually attracted to their parents. I went up to him afterwards and asked him if he thought Freud was talking metaphorically or literally, and he said probably a bit of both. More recently, reading Thomas Ogden in his book Rediscovering Psychoanalysis, I was struck when he drew attention to an important attitude of Freud's towards his work, that he saw himself as a kind of archaeologist, rediscovering ideas. Freud encouraged those interested in psychoanalysis to engage in a similar journey of rediscovery, saying of the work, "I shall not, however, tell it to you, but shall insist that you discover it for yourself." What does it mean to discover something of importance? I believe this process is central to every psychotherapeutic relationship, and maybe to every relationship of any depth. It is also true of relationships between groups, such as those between Māori and Pākehā. I learned a little more about this at the NZAP conference in 2008 at Waitangi, when talking to the now late Professor James Ritchie. James was a foundation professor at the University of Waikato and had a long association with research on biculturalism in New Zealand. He had a close involvement with Waikato iwi regarding their treaty claim. I spoke to him about my own bicultural journey. In my creative world, Māori ideas had become important, and I was finding myself playing with them and developing them, and I felt uncomfortable about the possible cultural appropriation involved. James listened to me speak of this and then told me a story of his own. As well as his work with Waikato iwi, he had a close Māori friend and mentor in the far north, whom he would regularly visit. They would sit around the fire and talk. James would listen as his friend told him stories of deep significance. Once James shared one of these stories with a Waikato colleague, and when the colleague asked him where he had got that story from, James told him of his friend in the far north. His colleague said, "Oh, you don't want to trust too much of what he says, he makes stuff up." The next time James visited his friend up north, he told him what his colleague had said, and his friend had replied simply, "That's right, that's what you do. That's how you discover what the story has to tell, make stuff up." I was encouraged by this to keep following my creative imagination as an important part of the process of exploration, and have found that it can help me discover things I might not otherwise have found. I believe that it needs to be accompanied by well-informed evidence and logic and grounded theory. For me, there are two broad aspects of the discovery process, the symbolic and the logical. These are not separate and interact with each other in both helpful and unhelpful ways. I believe that they alternate from figure to ground, each enhancing the clarity of the other. How might this apply to Freud and the sexual theory? Freud rediscovered sexuality in his work as a psychotherapist. In his autobiographical study, when writing about his idea that emotional excitation contributed to neurosis, he said, "I now learned from my rapidly increasing experience that it was not any kind of excitation that was the action behind the phenomena of neurosis, but habitually one of a sexual nature, whether it was a current sexual conflict or the effect of earlier sexual experiences. I was not prepared for this conclusion, and my expectations played no part in it, for I had begun my investigation of neurotics quite unsuspectingly." If that was his logical process, we can look to the Greek myths Freud chose to underpin his discovery, those of Narcissus and Oedipus, to get a sense of the symbolic in his work. These are both stories of a sexual nature and are, in my experience, still very much alive in the vocabulary of psychodynamic therapists. In contrast to this, the scientific aspect of the theory has stayed to a large extent in the 19th century. There's been much conflict and division among those influenced by Freud's theory since its inception. As a bioenergetic therapist, I'm particularly interested in the conflict that developed between Wilhelm Reich and his colleagues, and Freud and his colleagues. Freud was quite impressed with Reich, described him as having the sharpest intelligence in the Vienna Society, and referred patients to him. Reich presented his character analytic concepts as developments of Freudian principles. Freud disagreed with him about his strongly held belief that character should be interpreted before the patient's incestuous desires, however. At this time, Reich was beginning to fall out with some of his senior colleagues, particularly Fadown, over his strong emphasis on the centrality of sexuality, as well as his emphasis on the importance of analysing negative transference. Reich himself thought that his colleagues displayed an unwillingness to deal with negative transference because of their own narcissism manifest as their desire to be liked. Another area of Reich's conflict with Freud and his colleagues was over the death instinct. Reich noticed how quickly this concept, one which Freud himself admitted was not grounded in clinical evidence, was taken up by the psychoanalytic community at the time. This happened in the aftermath of the First World War, when the human capacity for violence was very much in the mind of Europeans. Reich disagreed with the death instinct theory and was initially supported in this by Freud, who agreed that it was important to base theory on clinical evidence, and if this could not be found for the death instinct, then it should be challenged. His encouragement was slowly withdrawn, however, and Reich became alienated from the psychoanalytic community. Speaking to his biographer Myron Sharaf in 1948, he said, "Breuer first had the energy principle and he ran from it. Then Freud had it and he ran from it. Now I have it and I haven't run from it yet." Like Reich, I think that the intensity of the capacity for violence has a deeply sexual basis. And I want now to introduce a concept drawn from population genetics, which I think gives a more comprehensive grasp of this. Back in 1968, I studied zoology parallel with psychology and have maintained an interest in the links between them. What population genetics predicts is well covered by Reich's sex-affirmative stance, but deepens our understanding of the connection of this to violence. In 1945, Sewell Wright proposed a population genetic model which takes head-on the often vexed question as to how the genes responsible for social behaviour can have evolved. He pointed out that in a randomly breeding population, such genes would be lost, as on the individual level, genes for social behaviour are disadvantageous to individuals bearing them. Wright saw a solution in the concept of neutral genetic drift, which is the process whereby a particular gene or group of genes can become fixed in a population in the absence of selective pressure. He proposed a population structure which allows the selection of genes behind social behaviour, one divided into small inbreeding groups. This allows these genes to become fixed in the small group on a chance basis, free from selective pressure, and by conferring their benefits to that group, increase its breeding success and their own prevalence. If there is a small amount of outbreeding, the genes are then spread to other groups and can eventually become fixed in the population as a whole. My thinking is that the ability of humans to learn and socialise in complex ways has evolved conjunctly with behaviours which foster small inbreeding groups and which allow a limited amount of outbreeding. As Freud elucidated by taking up the Oedipus myth, our search for understanding is directly related to sex, as was Oedipus's, and specifically involves a journey which negotiates the attractions and perils of incest and exogamy. Furthermore, this journey begins at birth, or before, as did Oedipus's, and potentially involves us in physical, emotional, and social trauma, both self-inflicted and inflicted by others. It also involves a logical approach, Oedipus's search for answers, and a symbolic one, the visits to the oracle. The way we learn both limits our social contacts and gives us potential for limitless social contact. This contributes to our tendency to inbreed, along with our obvious potential to have sex with people very different from ourselves, and can be seen as generating the breeding structure that Wright describes. The death instinct can be subsumed under sexual theory in this context. Our very ability for complex cooperation with other group members carries with it the shadow of intergroup and therefore interpersonal conflict. At its peak, this constitutes complex mass murder through warfare of those who are or who have become members of another group, and can also manifest within the group as, for example, the conflict between Reich and Faden. Reich identified frustration, repression, and regression as the sources of violence. I see these mechanisms behind both violence and the maintenance of inbreeding groups. When boundaries are challenged, symbols can both facilitate relationship and contribute to violence when they become concretized. When this happens, the other may be demonized and seen as worthy of attack. Relationship becomes lost in an ungrounded state of regression, repression, and frustration. As psychotherapists, our task is to help our clients negotiate and understand this process, even as we join them deeply in life's relational journey. One of my clients, I'll call her Mary, a Pākehā woman in her mid-20s, was ambivalent about therapy. She was strongly motivated and keen to make changes, and yet as soon as the second session, acknowledged that she was holding back, not only in her intimate relationships, but also from me. I've been here before, she said, about her unwillingness to express anger and sadness that arose for her as she told me about herself. Her father had died when she was 4, and as a young woman, she had not identified clearly as gay or straight, having had relationships with both men and women. We worked bioenergetically and somatically with the holding back resistance, which helped her break into deep open sobbing. The memory of sexual abuse as a 5-year-old came to her, particularly the fact that she had been unable to say no. There was no one there for me, she sobbed. The following session, she reported having made a visit home to her mother and brother and having been badly hurt by their rejection of her sexuality and her friends. She had had a dream following the visit of having made poems in PowerShell. 2 Maori men had helped her in this task. The power was cut in curling shapes which fitted together. Mary's association to these shapes was that they were beautiful and meaningful, not so verbal. In the dream, her mother had criticised the shapes abusively. The men in the dream seemed strong to Mary, however, strong enough to help her to stand up to her mother. I'd like to finish by returning to my own story following my talk with James at the conference at Waitangi. The talk and the conference strengthened my wish to ground myself more in my home environment, Whanganui-a-Tara. One way I have of exploring things that interest me is to do paintings of them. For me, this is a focused and meditative process, a relational one between me and the subject. That often opens up a new awareness for me. It is also a process in which I make things up. I'll talk about my painting of Ngāhue. Ngāhue is the taniwha who launched himself from the mouth of the Heretaunga or Hutt River and burst open the entrance to Whanganui-a-Tara, which up to that point had been a landlocked lake. His path follows undersea fault lines. A taniwha is often a personification of a great force, such as an earthquake, a powerful relationship, if you like. Ngāhue was also the name of the man who accompanied Kupe on the journey of discovery from Hawaii to Aotearoa. He is known as the navigator. His knowledge is seen as providing guidance for others to follow in his footsteps and those of Kupe. Kupe's story is recorded in the landforms, and the names of these forms have an intense sexuality about them. At the entrance to Whanganui-a-Tara is a reef, Te Tangihanga o Kupe, the grieving or calling out of Kupe. Further into the harbour is a rock, Te Ure o Kupe, Kupe's penis. Across the harbour entrance from Te Tangihanga o Kupe Reef is a headland known as Para Ngarehu, a headland which means the glowing embers, or perhaps a haka done with weapons to clear obstacles. In the middle of the harbour are 2 islands, Kupe's daughters, Matiu and Makaro. The painting shows the relationship between Kupe and Ngāhue, and here is where I'm making stuff up. The name Ngahwe also means gourds, symbol of fertility and container of all mankind and the hidden law. The Taniwha Ngahwe is believed to be alive today, inhabiting Whanganui Atara and the seas beyond. He comes and goes from the settling places, Heretaonga, on the shores of the harbour. Kupe is the male symbol of the net of whakapapa and ancestors. The harbour, Whanganui Atara, is female. Tara, as well as being the name of the son of Whātonga and the chief who settled the harbour, is also the A word for female genitals. The two islands in the harbour, Matiu and Makaro, are the children of the sexual union. The name Matiu refers to a rhythmical movement and Makaro to the parrying of this movement. The children, like all children, are literally the personification of the sexual act. Have I made stuff up? Did Freud make stuff up with the sexual theory? I believe that the understanding of sexuality as the ground for human relationship is deeply embedded in the unconscious and can help us negotiate the symbolic phenomena involved in our relationships and lessen the chance for violence. Sexuality is also a figure that can be developed consciously by the process of rediscovery, making things up and grounding them in reality. Thank you for listening. Tēnā koutou, tēnā koutou, tēnā tātou katoa. E hara I te mea no naene te aroha ngā nā tūpuna taku iho luku iho.
Okay, so without further ado, we'll welcome Mark Thorpe.
Thanks. Kia ora, Keith. Tēnā koutou, tēnā koutou, tēnā koutou katoa. My thesis this afternoon is a simple one, and that is that negative capability is central to many forms of the creative endeavour, particularly that of depth psychotherapy. However, negative capability brings within its wake many adverse anxiety reactions which are determined by intrapsychic, interpersonal, and societal causes. In psychotherapy, these anxieties need to be firmly held and contained by the psychotherapeutic frame. So the foreground of my talk is negative capability, and the background or the anchor is the psychotherapeutic frame. So John Keats, in a letter to his brothers talking about Shakespeare and his great creativity and oral abilities, thanks to Mary earlier on, defined negative capability as a state in which the person is capable of being in uncertainties, mysteries, doubts, without any irritable reaching after fact and reason. I know this is a long workshop, so I invite you to turn to the person next to you and spend 30 seconds, choose one of those abilities and say to them why you think it's important in psychotherapy. Go. I'll read them as you're there. Capable of being in uncertainties, mysteries, doubts, without any irritable reaching after fact or reason. Quick discussion. Okay, if I could just stop you there. The aim of that was to prevent the post-lunch dip and to get you involved, which looks like you are. Thank you. So let's take another quote, and these are all from the area of art and literature. I sense a sort of transfusion and transmission of consciousness to identify myself with the object. Similar to what you were saying earlier on, Rod. So it's a transfusion and transmission of consciousness and an identification, a loss of identification of myself, identifying with the other person or their client. I embody myself with a character while I am painting it. Now, the progress of the artist is a continual self-sacrifice, a continual extinction of the personality. Very different to some of our Western concepts. Okay, then moving on to psychotherapy, we have Freud's idea of free association. Okay? And free association is not to focus on one particular thing or not to only talk about your problems. It's to focus generally and to talk about whatever comes to mind. The aim is to bring up the unconscious, to allow negative capability, if we use that term, to flourish. And I see Vicky smiling in the back there. We had a talk this morning which someone spoke about that. Okay, so that's what the client is asked to do. The therapist or the analyst, on the other hand, is asked to be analytically neutral. And that doesn't mean to sit there all poker-faced and catatonic. It means to be neutral between various aspects. If you take the structural model between the ego, the superego, between the conscious or the unconscious, between the manifest or the latent content. And in a similar way, evenly hovering attention is to hover over all of those, to be open and free to consider as many possibilities as there are, rather than to decide on a formulation and to go with it. That's the DSM-5 diagnosis, that's going to determine my treatment. No, you'll stay back and use evenly hovering attention. Okay, Freud also said there's a danger of never finding anything but what we already know. So it's that sort of fixed loop, and I particularly like this picture because maybe at some stage he also couldn't look outside of the theory, although we know he had 6 different theories that he worked on. Wilfred Bion has taken these ideas of negative capability and written extensively about them, and they've infiltrated our therapeutic practices, mainly from Bion. He says that insight arises best when the thinker's existence is no longer necessary. Okay? Very interesting work that he had on thinking. When the thinker's existence is no longer necessary, I lose my ego, the Buddhist concept of no me, my, or I, just in the flow, in some sort of negative capability piece. There's a picture of Bion. Bion's most famous comments were that memory, desire, and understanding are filters that interfere with accurate observation and listening. So, of course, his famous statement of attempt to enter every session with no memory, desire, or understanding. And he gave some advice of how to, through thought suppression, or disciplined denial of what's going on. Now, Freud wrote a lot about it, so did Bion. There are no clear details of actually how to do it. There are things of how not to do it. And people like Mark Epstein, who's written a lot about mindfulness and Buddhism, has subsequently shown us that perhaps in mindfulness practice, you actually learn those things a lot more than just knowing them theoretically. Another favorite concept is that of lying fallow. Very nice term, Masood Khan. And he defines that as alert quietude and receptive, wakeful, lambent consciousness. Okay. So the lying fallow needs time, it needs space, but like 18 minutes in a TED talk give you a lot of time to process. So Ken Isold has written also considerably about the negative capability, and he defines it as the capability to live with and to tolerate ambiguity and paradox, to tolerate the anxiety and the fear, and to stay in a place of uncertainty in order to allow for the emergence of new thoughts and perceptions. Remember Freud's thing, if you think as you always did, nothing's going to change. It's a picture of Ken. And Mark Epstein, who I quoted a few seconds ago, says that the Buddha encouraged the consistent doubting of all fixed assumptions about the nature of things, which in a way is what psychotherapy is about. The client arrives with a fixed pathological way of looking at things, and you start doubting that. You start trying to find new ways of dealing with it. Also like the concept of impermanence, in that the way we structure, the way we language our life is impermanent, and we can find other better ways of doing that, to catch up from the past, bring it into the present. So I've basically shown you a whole lot of images and quotes and leaving it up to you to link, because I presume everyone does slightly different therapy. But just a few thoughts of negative capability. I think it's important because it provides a process or an avenue which through therapists assist their clients to understand and move out of their frozen, rigid style of maladaptive living towards a healthier, better way of living and being in the world. So the client needs the time, the space, and the safety and the containership to process, to progress, and to develop. So are there any negatives of negative capability? Are there any negatives of looking at the new? Are we all quite okay with discovering new things? Of course not. So, and taking on the extreme, Francis Tustin spoke about the very primitive anxieties of dread and, the dread of falling and dissolving. Okay? So we've all got those, as Bjorn showed us, all got that psychotic part. But we all need to be contained. The more we explore, the more containing we need. Once again, Wilfred Bion spoke a lot about the fear of the contained. It's very difficult containing all those feelings, and we ourselves need to be contained as well. It's not just intrapsychic difficulties we have. This is a mural outside the AUT library. It's actually subsequently been withdrawn. I'm not sure why. Very tall. It's about as tall as the roof. And the link to this talk is that Adam dared take a bite of the apple of knowledge, in other words, so that he could use his negative capability. He could think, he could criticize, and for that he was kicked out of the Garden of Eden with Eve. Socrates spent his life educating the youth of Athens to try and think critically, to be open, to be curious, and for his sins he was sentenced to death. And of course he chose to drink hemlock. Great example for all philosophers. Watch out, don't think too much, don't think too carefully. We're all within limits. We all know about books that have been burnt. Most cultures have been through that. Some of us don't burn the books, we just don't allow them into the libraries, things like that. Journals do that right now. But I'll give a sort of a similar talk. There are many, many pictures like this. Very bright psychotherapy university students doing the burning of the books. And we all know the common adage, watch out, don't be too curious. So what do we do about that? We use the therapeutic frame in the therapeutic setting to contain them. So this is the ground of the talk. And the frame generally is, most of us think of the frame as the regular time, space, place, fee from a therapist who's caring and containing, and the therapist who themselves is contained by theory, training, the room in which they do the therapy, the society to which they belong, the ethics code, as well as support from the wider society. Took this photograph beginning of the week in Wellington. We need a strong anchor. The more you want to explore, the stronger anchor you need so that you don't just disappear or fall forever. Jung spoke a lot about the alchemical vessel, combining of a whole lot of elements. and they were very well contained, kept together, and heat applied. Couldn't allow them to move out, otherwise they'd flow all over the place. Same sort of thing as the therapy. It needs some form of containing, some form of safety. Here's the South African version of that. You don't put the top off all the time. You let it steam, you let it boil, you let the elements mingle like that, and it's got a very strong container. Sort of a simple analogy here. If you want to dive deep into the unconscious, you can't just swim. You need a container. You need an exterior shell. You need a supportive therapist, for example, like that. And here is a picture showing you that the holding environment, as Tom Lewis many years ago as a keynote at the NZAP told us, is not only the human domain. Okay, so when things are difficult in therapy, you need to be held. Some people say physically, others say metaphysically. Like that. And 13, and one more. Children early on are wrapped up, swaddled. Early anxieties are contained. So this is a summary, my visual attempted summary of my talk, in that negative capability, the curiosity, the openness, the processing, looking for something new, is one of the vital components of psychotherapy. Without by itself, it's no good. You really need a strong anchor or a strong container, the therapeutic frame, to do that. The two, of course, are in dialectical balance with each other. Now, see, I've got a few minutes, so I'd like to give you two brief examples, both of which are somewhat personal. I've experienced myself. One is a 10-day Vipassana meditation retreat, and the other is psychodynamic therapy on the couch. These two, on the spectrum, tend to be far on the side of very strong containers. For example, the 10-day Vipassana, no outside contact, none of these sort of things that tell you you've only got 13 minutes left. You're told exactly when you eat. When you meditate, you start meditating at 4:30 by a bell, you finish at 9, you go and sleep, they switch the lights off. A whole host of things that some of us would see as very rigid. However, this external containing and routinization allows an incredible internal psychic freedom. Spend the whole day with your eyes closed, very strict rules, but all sorts of things appear up. So that's the paradox, or that's the dialectic. The stronger the hold and the clearer the frame, the more you can dive down deep or feel the psychic freedom. Psychoanalysis, most forms of psychotherapy are similar. You pay for the sessions that you miss. You don't change the times, sort of the more orthodox psychoanalysis, you meet a few times a week. And it's very clear what your role is. It's to free associate. A lot of people see that as rigid. But I would put forward the view that very firm containing like that also allows an extreme amount of freedom. So it's not a social meeting, it's psychotherapy. So just to say once again that the therapeutic frame allows the containership of the negative capability, or the freedom, curiosity, or the processing. Any questions? Comments? We've got 2 minutes. 15:49. Yeah.
I'm wondering how you see, perhaps a bit in line with what Josie was talking about, how do you see the therapeutic paradigm with the negative capability that you talk about, sitting with the medical model, which so many of our clients, patients are steeped in, how to make that transition when we're about encouraging negative capability, which is quite opposite to what the medical model would perhaps encourage.
No, thank you. I mean, and that's in a sense why I gave this talk and why I'm interested in these things. And negative capability is not the only thing in therapy. There's a lot of other things. And it's not only the medical model, it's the psychological behavioral therapies that are like that as well. So there's a big difference between free associating or talking and exploring and being open to things than reaching for the manual and saying, what homework haven't you done and why didn't you do it? And how does that link with the DSM, things like that. So my answer is with great difficulty. It sneaks in everywhere. We teach a counseling psychology course at AUT that's a little bit like the clinical psychology, but we try and bring in more things like this. CBT is also changing to say that. We've got someone who works for us, calls herself a CBT therapist, but does a whole lot of other things. That would include this sort of lying fallow, talking, thinking, processing, not just the doing. And that's the whole thing between the being and the doing.
I think it's not just the model that we're talking about.
Okay, yeah.
It's the person, isn't it?
Sure.
I think people who say they're medical, psychiatrists, medical model practitioners who hold the client respectfully, thoughtfully,
Yeah.
and demonstrate the negative capability, and at the appropriate time reach for the DSM medical.
So it's a combination of the two. And you probably also know humanistic therapists are very rigid and autocratic and don't do that at all.
That's right.
So,
Exactly.
thank you. 18 minutes on the dot. Kyle.
Thanks, Mark. I just wanted to say that I think it might just be the word that I'm getting hung up on, the negative capability, but I was wondering what your thoughts are about the relationship between that and, I guess, the positive version of flow, which is also in the creative world or even in sports psychology, about how we enter fully into the moment and with an absence of anxiety or self-consciousness, create very positive things.
A very tricky one, and I've been thinking about it a little bit. And I wanted to change this to a positive capability, you see, so because I've got a bit of a negative capability, I say negative stuff. But when you read Keats and a few of the things, you sort of need to keep the negative because it's like a photographic negative. It's not this, it's the opposite of it or the negative of it. So worrying that I'm going to distort the concept, I've really kept it. It is quite similar, though, to flow in all sorts of ways. Those are just different terms. I like this because it's been going for a long time, and it's used a lot in art, literature, as well as psychotherapy. Keats is quoted hugely. Great. Thank you.
Oh, hello, Mark. I just wanted to not talk about anything you're talking about. I know what negative is, therapeutic and all that. But what I want to say is that you're the first speaker I could hear today. And, I think you did very well.
Thank you.
And I felt you were talking to us. I was telling my friend here about, how well you're doing your job. So that's really what I wanted to say. And you're the first person I've heard today.
Kia ora.
I think that's a good note on which to thank you, Mark. Thank you. I want to thank all the speakers, Josie, Rod and Mark, for being willing to experiment. I also want to thank you as an audience for being willing to experiment and deal with the constraints of time. I was struck by the Greeks had two words for time. They had chronos, from which we get chronological, and they also had kairos, which means appropriate time. And I'm always struck by the sort of interplay between, what is appropriate time? What is 18 minutes the appropriate time, or is it a frustrating time, and so on. I was also mindful of the TED, as I said at the beginning, stands for Technology, Entertainment and Design, and I want to offer a different interpretation of that acronym on the basis of the three talks we've heard today. I think they were all thoughtful, erudite, and distinctive. And I really want to thank the three of you for that. Thank you. And they all pretty much came in on time, but we have something a little bit more than a chocolate fish. We have 15 minutes break now before a conference gathering in this whare, and if you would, as many of you as possible, could move chairs, because we're going to have to strike the room and redesign it in 15 minutes. If those of you who could carry a couple of chairs and put them all at the back on the left-hand side, that would be really great. Thank you. Kia ora koutou.